Welcome to our recording, PSSD, Losing Your Sexuality to Antidepressants After You Quit the Meds. What you need to know for your clients who suffer from PSSD. PSSD is Post-SSRI Sexual Dysfunction. The presenters today are Yasi Parani, Emily Gray, and Margot M. Mays. The content warning. This video, unfortunately, is not a happy one. We will discuss how people have been affected by PSSD in physical, mental, and cognitive ways that have resulted in great suffering and desperation among those affected. We have an activity scheduled at the end of this video that concerns eating a piece of candy, and we have options for those who want to participate, and you can always just end it at the end. We ask that you take care of yourself as needed throughout this video. Who are we and why are we doing this? We are three different people affected by PSSD in different ways at different points in our lives. We want to spread awareness about PSSD so that people can exercise true, informed consent before starting SSRI, SNRI treatment. We hope that our message will be heard by healthcare professionals, providers, researchers, educators, policymakers, and the general public. The agenda for this video, we have our goals and objectives, our PSSD we'll talk about, what the treatments are, we'll have resources at the end, and then that little activity I talked about. The goals and objectives. So by the end of this video, you should be able to recognize the myriad of side effects that could be attributed to PSSD, understand the impact of PSSD on people's lives, and what you, as a sex therapist, counselor, or educator, or healthcare professional, what you can do to help others. This is a little bit about me. My name is Margot M. Mays. I'm a certified holistic sexuality educator. I'm on a mission to take my 20 years of living with chronic pain and use my experiences, my experiments, my education, and my wisdom to help others find their own tools to keep their sexuality. I'm a middle-aged, bisexual, highly sensitive, pale-skinned and freckled, disabled, cisgender female living with chronic pain in a monogamous married DS relationship to the married man of my dreams, and Snow White to any animal that yonders in my yard. I'm the leader of the Asex SIG for Sexuality Educators, and I co-founded POSE, the Professional Organization of Sexuality Educators. Along with a list of chronic illnesses and pain, I suffer from PSSD, primarily the PDOD symptoms.
Hi, everyone. My name is Yasi Parani. I am a cisgender, heterosexual, biracial woman in my 30s and a settler of Indian and mixed European ancestry. I live on the traditional unceded territory of the Musqueam, Squamish, and Tsleil-Waututh nations, and also known as Vancouver, BC. I'm a registered clinical counselor with the BC Association of Clinical Counselors and a registered social worker with the BC College of Social Workers. I work from a trauma-informed, anti-oppressive, and harm reduction approach. And in my clinical practice, I specialize in supporting people who suffer from post-SSRI sexual dysfunction. And I suffer with the condition myself. I'm passionate about working alongside people with PSSD to help them come to terms with what has happened to their bodies and to find ways to channel their loss into positive action.
Hello, my name is Emily Gray. I'm a medical activist using my ongoing personal experience of PSSD to raise awareness of the disorder among healthcare professionals and the public. I am one of the founders of the registered nonprofit Canadian Post-SSRI Sexual Dysfunction Society, which can be found at www.pssdcanada.ca. I am networking with PSSD sufferers around the world and working with researchers at Queen's University and University of Ottawa to acquire more information about this understudied iatrogenic condition. I suffer from PSSD. So what is PSSD? PSSD stands for Post-SSRI Sexual Dysfunction. It can be caused by selective serotonin reuptake inhibitors, SSRIs, or serotonin and non-repinephrine reuptake inhibitors, SNRIs. Both are commonly given for depression, anxiety, chronic pain, and other mental health issues by a wide variety of medical professionals. Though the characteristic symptom is reduction or elimination of sexual function, common accompanying symptoms include emotional blunting, cognitive dysfunction, and tactile numbness. It can occur during treatment or withdrawal of SSRIs or other antidepressant medications. It can last months, years, or indefinitely. There is currently no known reliable treatment, and PSSD can profoundly negatively impact sexual and mental health. So this video is not to advocate against the use of SSRIs or any other antidepressant medication, but it's to bring awareness of PSSD and to prevent people's sexuality from being taken away without their consent. We are pro-informed consent for all patients. So here's the typical story of PSSD. Someone is feeling off, so they go to the doctor and they might get prescribed an SSRI for a variety of reasons. But something's still not quite right. Often, SSRIs will bring on sexual problems. So these can be, and also non-sexual problems. So the sexual problems can be a lack of sexual desire, libido, and sex drive, or a lack of response to sexual stimuli. Reduced sensitivity or numbness, reduced or lack of sensitivity in sexually sensitive areas, paresthesia, like burning or prickling sensation, erectile dysfunction, or reduced or no nighttime erections. And sexual problems can also include premature or delayed ejaculation, decreased vaginal lubrication, orgasms can be delayed or non-existent. These are common symptoms while on the SSRI. So these are all common symptoms while on the SSRI. They become PSSD once these symptoms persist for at least 3 months after coming off the SSRI. Emotional problems can often accompany PSSD. There are wide reports of numbness or blunting, anhedonia, which is the inability to feel pleasure, apathy or lack of interest, and worsened depression. And having your sexuality stripped from you or reduced can have profoundly negative consequences for other aspects of your mental health and quality of life, such as relationships, self-esteem, identity, self-expression, mental health, sexual health, even your physical health. And it can even have economic and educational impacts in that these mental health struggles can prevent you from advancing in the workforce or your education. Frequently reported co-symptoms are sleep disturbances, fatigue, lighter or less frequent menstruation, diminished skin sensitivity, diminished senses, and dry hair and or skin. Cognitive symptoms can include reduced memory, delayed cognitive processing, disorganized thoughts, difficulty communicating, inattentiveness, reduced creativity, lack of imagination or visualization, and loss of dreaming at night. A closely linked syndrome is persistent genital arousal disorder, or PGAD. This can also be triggered by SSRIs, and in some ways can be thought of as the inverse of PSSD. And another closely related syndrome is pleasure dissociative orgasm disorder. This is when your body has an orgasm, but there's no endorphins that are released in your brain. So you go into a dissociative state and you are not registering that orgasm is pleasurable. Syndromes with similar symptoms, a similar symptom profile, which may have a linked underlying cause, are post-finasteride syndrome, or PFS. Finasteride is a drug given to prevent hair loss and also treat enlarged prostate. And post-retinoid sexual dysfunction, and that is a drug given to prevent wrinkles. So many people are being treated incorrectly because the healthcare providers are unaware of the existence of PSSD. They may attribute symptoms to a psychosomatic issue and try and treat the problem with mental health treatments, including more SSRIs. So PSSD is not a mental health disorder. but it is a combination of side effects from the medications that were taken due to having a mental health disorder. It is an iatrogenic injury from mental health medications. The 5th edition of the Diagnostic and Statistical Manual of Mental Health Disorders, the DSM-5, does make reference to PSSD and states that in some cases, serotonin reuptake inhibitor-induced sexual dysfunction may persist after the agent is discontinued. Some have been diagnosed with delusional disorders and prescribed antipsychotics rather than being diagnosed with PSSD. The low libido associated with PSSD is often incorrectly blamed on the depression. The sexual problems from SSRIs can induce depression, and doctors will often offer more SSRIs as a treatment, which can worsen the PSSD. But it should be noted that PSSD can also occur in people who were taking SSRIs for reasons other than depression. Many people have their PSSD symptoms minimized and dismissed. That only compounds their suffering. When patients' experiences are not validated, they may go into a spiral of self-blame, shame, self-loathing, depression, anxiety, or even suicidality. The therapist's job is to validate the disease and any emotions people are experiencing about the loss. Many doctors commonly do not inform patients about the possibility of sexual dysfunction during or after treatment. This is due to a lack of widespread awareness within the medical community and the public about PSSD, and also discomfort in discussing sexuality and sexual health. PSSD is thought to be widely underdiagnosed and underreported. Many people who suffer with PSSD are likely unaware that they have it. It is easily mistaken for other ailments. Sexual dysfunction persisting after antidepressants is not classified as PSSD until it has continued for 3 or more months. Misattributing PSSD symptoms to psychogenic or psychosomatic causes compounds suffering and creates self-blame, animosity towards medical professionals, and further alienation. The alienation and self-blame can further disrupt relationships, self-worth, and identity. Avoiding misdiagnosis is essential. PSSD patients have been diagnosed as delusional and mistreated with antipsychotic drugs. Not being aware of PSSD can lead to patients not aware of the risk of harm when using SSRIs and SNRIs, patients and prescribers not being able to recognize the harm SSRIs or SNRIs can cause, or prescribers not monitoring the harm SSRIs and SNRIs cause. For many, the symptoms do not start until weeks after stopping the SSRIs. For some, the symptoms occur from just taking a few pills, and they may not become diagnosed until years after exposure. PSSD can last for years with no working treatment at this time. PSSD sufferers feel violated and silenced. We took the medication under the information that we might have a period of low libido during treatment, but we were never informed that our sexuality could be taken from us indefinitely. This was non-consensual. And now I will pass this presentation over to Yassi.
So, what are the treatments and what can I do for my patients, clients, or students? Unfortunately, there is no known reliable treatment for PSSD. We hope that changes, but for now, there isn't anything. What is being recommended at this time to anyone who thinks they might have PSSD is to seek out a medical doctor who is familiar with the condition, or to bring literature to your doctor for them to learn about it. See your medical doctor to rule out any other medical condition, check your hormone levels, and seek out a mental health care professional for talk therapy, coping, and emotional support. Seek support from family, friends, lovers, the internet, or anywhere you can find it. Some medications are prescribed for general sexual dysfunctions, but are not known to help people with PSSD-induced sexual dysfunction. Some people recover spontaneously, but there is no predictable path forward and no known interventions that can aid in the recovery process. Some people experience symptom improvement, but then experience crashes where the problematic symptoms return. There is very little research on PSSD. More systematic research is needed to assess prevalence, as well as studies to determine the possible underlying mechanisms contributing it to, so understanding the pathophysiology and etiology. Some prevalence research that we do have, I'll explain here. So a 19-year retrospective cohort analysis recently published in the Annals of General Psychiatry found that 1 in 216 males who took a serotonergic antidepressant experienced erectile dysfunction long after discontinuing the medication. And then a recent survey of 874 youth found that 12% experienced persistent genital numbness despite stopping the medication. Genital hypothesia, commonly referred to genital numbness, is a reliable indicator of PSSD. This data is not yet published. There's a survey on patient experiences currently being done, and we encourage any of your clients or anybody you know to participate. Queen's University in Ontario is currently gathering this qualitative data on PSSD sufferers through a longitudinal survey. There's a link in the handout to contact Dr. Carolyn Bacall and a link to access the survey there. Please share widely. Different theories have been proposed to explain the pathophysiology of PSSD: epigenetic gene expression, dopamine serotonin interactions, serotonin neurotoxicity, and hormonal changes. People are desperate in this community and experiment with many things, trying anything to get their sexual health, physical health, and mental health back. People appear quite angry and hopeless who are experiencing this illness. Margot's been in some of these online communities and sort of comparing the subcultures and has noticed that compared to other communities of people and online forums concerning chronic illness and chronic pain and sexuality and disabilities, there's quite a specific tone in this community. Testimonies from online community groups, are sharing that, on these like subreddits on PSSD, we sort of ask them for examples of acts that show, what's really going on for people and that exhibit some of the desperation they're experiencing to try to have any effect or any result on the condition. And, we've learned that people are engaging in dangerous experiments. I also have clients who are experimenting, and they're being advised by other sufferers in these community spaces to try different drugs to improve symptoms. People are being told to lie to their doctors in order to gain access to medications for these experiments. For example, saying they have an illness that medication would be used to treat, so that their doctor will prescribe it so they can try it as an experiment to try to resolve their PSSD symptoms. And people have been injecting themselves with hormones and steroids in the most unregulated and dangerous way because somebody wrote a 39-page theory on why he thinks this disease is caused by an estrogen issue. I've also seen multiple posts of people trying methamphetamine in the hopes of lifting their sexual and emotional anhedonia. People are also reinstating the SSRI that traumatized them and injured them in hopes of reversing the effects of PSSD. But the majority of time, it makes it even worse. How can you help as a sexuality educators, sex therapists, and counselors? Be the person that we can talk to about this. People stop taking their medications because of sexual side effects, yet are embarrassed to talk to their healthcare providers about their sexual health. As sexuality educators, we're not here to provide therapy to help manage emotional distress, but to be informed of PSSD, spread awareness about PSSD, and work with your clients to provide the sexuality education they need. Help them turn up the volume on what little pleasure they do experience. As mental health professionals, we're not here to treat patients medically, but to recognize possible PSSD and help manage emotional distress, grieve the loss of their sexuality due to a non-consensual act, and help process the ongoing trauma. Here are some communities that people can reach out to for more information and support. There's the PSSD Network, the Canadian PSSD Society, the PSSD Forums, and the German PSSD Society, the UK PSSD Association, and the Italian PSSD Society. We need public awareness, more research, more education to medical professionals, education to mental health professionals. We need treatment. We need support. We need hope. And we need media attention. Not everyone has the same side effects from PSSD. So your clients, patients, and students, they all may need unique things. Work with them to figure out what their unique needs are based on their symptoms.
This video was dark and stormy and not joyous, similar to PSSD. But we don't want to leave you feeling blue. So we're going to do a little mindful exercise that you can be taught to your clients or your students to help them kind of enhance the pleasure that they feel. I call it narrating your pleasure. This is the little activity. This is something that I do. You can take a gulp of liquid in lieu of a piece of candy, or you can have a piece of candy and put it in your mouth. Or you can remember eating candy or liquid if you don't have anything by you. So you can do this anywhere you are. Or you can even hold an object in your hand. All it is we're going to be focusing all of our attention on one thing, really, really focusing. So I use this game during sexy time to combat my PSSD. I am retraining my brain to focus on the pleasure and not the disassociative part because I have PDOD. So when I have an orgasm, my brain disassociates. So trying to bring it back, I'm trying to focus as much pleasure. And I found if I narrate it in my head, it's an extra step. So what I do is I take a piece of candy and I can put it in your mouth. You can do this right now. Take a piece of candy in your mouth and kind of focus on it. And if it's hard to do, use like a cinnamon candy or like something that's hot or a strong peppermint so you really feel the tingles and everything. Now you're going to focus on each sensation. How does it feel? There's a texture. Is there a smell? What does it feel like on your tongue? Does the candy melt and it starts to get softer or little sharp spots? What about, is it up to your teeth? What if you run it up on your teeth and does it make a noise, or do you like that? Does it taste change as it starts to melt? Is it rough? Is it tough? Does it move it around inside your cheek? And you can narrate this like as like a 40s gangster, like, oh, see, look at that little candy. Oh. Or you can do it as like some funny character, something that makes you only think about this and you're not thinking of anything else in the world. All your brain's focused on that pleasure, on that mindfulness. So that's mine. So what can work for you? What could you teach to your client? What you can work with their client to help them focus their pleasure? And what I feel like is maybe if we can have those sufferings, the ones who are suffering, who feel like a little bit of pleasure, maybe we can make it a little bit more through these exercises. That's what my hope is. So these are our references that we had throughout the presentation. If you want to get in touch with us, these are our emails to reach Yasi, Margot, or Emily. And just thank you all for coming. If you want to reach out to the National Suicide Prevention Hotline, or if you need to reach a sex therapist, you can reach the asac.org. They have a list of sex therapists in America. And thank you. Thank you for taking your time to be educated on PSSD. We hope this will help you better treat your clients who suffer from PSSD, and you will help us spread awareness. Thank you.